Yes, sir, we are live.
Thank you, Shreya. Good evening, everybody.
Good evening.
Good evening. Today we are having a live session discussion on the examination of the neck swelling other than thyroid. First of all, I welcome Professor Robinson George. Now, all of you know him very well. He's a professor and at the Department of Surgery, Pushpagiri Medical College. Robin, welcome you for discussion. You know the discussions.
Good evening, sir.
Very good in
Good
all
evening,
the
sir.
medical discussions. Good evening and welcome. I welcome uh, my dear friend and Assistant Professor Kishan Rao. Assistant Professor in AJ Medical College. All of you know that he has got a big network channel in White Army. Kishan, welcome, Kishan.
Thank you,
I
sir. Thank you so much.
I also welcome, very nice of you, Kishan. I also welcome Professor Manoran sir from Pondicherry. He said he'll join soon. He's regularly joins us. When he joins, I welcome him. I also welcome Professor Srinivasan from Coimbatore. He said he'll join. He'll message me when he joins. So whenever he joins, welcoming beforehand only. I welcome presenter Ajay B and Megha Kapoor, both of from Kasturba Medical College in Mangalore, from our college.
Good evening, sir.
Good evening, sir.
And good evening. And today discussion is next one presentation. Without much delay, I think Robin, with your permission, will ask the student to present. Kishan,
Yes,
just open your camera. Let viewer have your face once. How exactly? Okay, thank you, Kishan. Very nice of you. This is our dear Kishan. Divya, welcome. He was my student and he's now working in Gujarat. Divya,
Thank you, sir.
welcome, Divya. Welcome everybody. Without
Good
wasting
evening, sir.
any delay, we'll go ahead with the presentation. Shreya, go start with the PPT.
Can start.
Start, Ajay. Start.
Good evening, everyone. Thank you, sir, for this opportunity to present this case. And the case presentation will be on neck swelling. Next slide. So the patient, Mr. X, 55 years old male, shopkeeper by occupation, hailing from Kundapura. Date of admission is on 6th November 2024, and the date of examination is on 7th November 2024. Coming to the chief complaints, swelling in the left side of neck since 4 months, ulcer over the swelling since 2 months, and pain over the swelling since 1 month. Coming to the history of presenting illness, patient was apparently asymptomatic 4 months back, following which he noticed a swelling over the left side of neck, which was insidious in onset, initially smaller in size, approximately 1 into 2 centimeters, and now progressed to the current size of approximately 8 into 10 centimeters. Swelling is associated with an ulcer with serous discharge since 2 months. Pain is present over the swelling since 1 month, which was insidious in onset, dull aching in nature. It was of diffuse type, mainly present over the ulcer. Patient had undergone CBNAT at Taluk General Hospital, Kundapura 1 month back, and the test result came out to be negative. History of loosening of teeth is present. There's no history of fever. There's no history of similar swelling elsewhere in the body. There's no history of cough, hemoptysis. There's no history of dyspnea. There's no history of hoarseness of voice. There's no history of dysphagia. There's no history of ear pain, deafness. There's no history of decreased appetite and loss of weight. Coming to the past history, the patient is not a known case of diabetes mellitus, hypertension, asthma, TB, cardiac or renal disorders. There's no history of similar complaints in the past. There's no history of exposure to tuberculosis patients. Patient had undergone an eye surgery 20 years back. There's no history of exposure to radiation. Coming to the family history, patient's father is a known case of diabetes mellitus. There's no history of similar illness in the family. There's no history of tuberculosis cases in the family. There's no history of any malignancies in the family. This is the family tree. Next one. Coming to the personal history, patient consumes a mixed diet. Appetite is normal. Sleep is disturbed due to pain. Bowel and bladder movements are regular. History of consumption of alcohol is present for the past 30 years, 2 quarters per day, and the patient had stopped consuming 2 years ago. There's history of smoking BD for the past 30 years, 1 packet per day. Next. Coming to the summary, 55-year-old male presented with chief complaint of swelling over the left side of neck since 4 months, which gradually progressed to the current size of approximately 8 into 10 centimeters. And swelling is associated with an ulcer with serious discharge since 2 months, and pain is present over the swelling since 1 month. The possible diagnosis could be lymph node enlargement, probably due to secondaries in the cervical lymph nodes, tuberculous lymphadenitis, and lymphoma.
Wait. Oh, okay. That is okay.
Yes, sir.
Just show the photo. Next slide, Shreya.
This is the next slide.
Next slide.
Next slide, Shreya. That photo
Next
you have
slide.
to show.
Photo.
Okay. Okay, all of us. Now go back to the history. First slide. Robin, because they are from my college, you start answer questioning them first. Then I'll discuss. The patient will discuss.
Okay, sir. Thank you. Good presentation, Ajay.
Thank you, sir.
The main complaint of the patient is a swelling over the left side of the neck, insidious in onset, 4 months back, right?
Yes, sir.
So just a doubt, the approximately size 182, did the patient say that you measured it?
Sir, he showed it in his hand, sir. Like he
So
just
finger breadths, yeah?
showed
So
finger,
finger breadths.
yes,
So
finger
yeah,
breadths.
okay. The site of it onset is fine. Nothing else to mention in that. Swelling is associated with an ulcer with serous discharge. What was the
Yes, sir.
history of the ulcer? How did it develop?
Sir, actually,
Mode of onset
he,
of that ulcer?
Insidious in
sir,
Spontaneously
onset.
initially insidious in onset, sir. Initially, like patient started having first the lymph node area was hard, and he started having like softer areas over the node, and later the ulcer developed it.
So then it developed with the serous discharge since 2 months.
So
Okay,
with serious discharge.
so that's it. Just spontaneously.
Yes,
No
sir.
history of
Spontaneous.
trauma, nothing of the sort.
No
Okay.
history of
Then
trauma,
third
sir.
is pain is present over the swelling since 1 month. Dull aching with the diffuse type mainly over the ulcer. Okay.
Okay. This is Sibinat. He told patient told himself
Yes,
told
sir.
Sibinat or
Patient told the
what
CBNAT and sir, he told CBNAT, he mentioned, and I even cross-checked the reports he gave me.
Okay.
Yes.
So next slide. Robin.
Ajay, you said history of loosening of teeth present. Okay, probably poor hygiene. No history of fever. No history of similar swelling elsewhere in the body. Your
So
differential
to rule out
diagnosis?
lymphoma, sir. To rule out lymphoma.
Lymphoma. Okay.
Yes.
No history of cough, hemoptysis, dyspnea. Fine. You have covered all the other features. Yeah, ear pain, deafness, decreased appetite, and loss of weight. Okay.
Right. Why
Yes.
all this history is important, Ajay?
Sir,
Cough,
to rule out the primary cause, sir. To primaries, so this can cause a secondary lymph
okay.
node in the
Hoarseness
neck.
of voice. So what you are thinking in keeping in mind?
Sir, what's it?
Hoarseness of voice. So what you are
Hoarseness of voice, sir, to rule out the carcinoma of the larynx.
okay. Dysphagia.
Dysphagia to rule out carcinoma of pharynx or the esophagus also could be
Why
carcinoma of the.
deafness? You are specifically asked. Why you
Sir,
are
deafness is to nasopharyngeal carcinoma to rule out nasopharyngeal.
okay.
Yes, very good. Yes.
Sir, in nasopharyngeal carcinoma, there might be serous otitis media,
Causing
which
the
can
deafness.
cause
Conductive deafness is seen.
conductive deafness.
Okay.
Yes, right. Yeah.
Okay. Next slide.
So,
Robin.
No history of similar complaints in the past.
sir, this,
Yeah.
4 months back, 2 months back, na. So
yes, sir.
4 months.
So, yeah, just to rule out recurrence or any,
Recurrence of lymphoma. Your working diagnosis
no,
is
not
approximately.
lymphoma,
Yeah.
sir. Just in case of a secondary,
No, that
In
that
case of
will
a
have
secondary recurrence or secondary.
that will have a
no, sir.
treatment history. No,
No,
you would have told
yes, sir.
treatment history.
So
What
that's
is
the
the
whole
similar
point. So no
complaints
history
he
similar
said?
complaints in the past. You've given us a working diagnosis of lymphoma. So
Yes, sir.
let's say he was treated for lymphoma. So the patient
Yes,
is
sir.
having remission or a relapse, right?
Yes, sir. Yes,
Yeah. So
could be.
that would be a very
Uh,
scary point to add. There are similar
Similar
complaints in
complaints.
the
Yes, sir.
How
past.
how it is relevant? Understood? No,
Yeah.
unless he has
Hmm.
undergone treatment, all those things.
Yes, sir.
Doesn't make any reason for to put that.
Hmm.
History of exposure is fine. No history of exposure to radiation. What's the significance in past history?
Sir, in case of childhood lymphoma, sir, the main modality is radiation therapy. So I just wanted to rule out that there is no radiation.
Okay, next slide. Next slide, Robin. Okay.
Yes, sir.
Okay.
Okay, sir. No history of similar illness in the family. Again, lymphoma you're talking about, or
What is the similar illness
Yes.
means? What?
So any
so, so,
malignancy, I was actually
You have specified
so
malignancy and
yes, sir.
tuberculosis. Then what
Yes,
else
sir.
similar illness will come? So that sentence will have any
Yes,
value
sir.
to that. Okay. That
Yes.
is-
rest everything is correct. Yeah, diabetes, history of TB, and malignancy. Fine, that's fine.
Yes.
Yeah.
Next slide.
Sleep is established. Consumption. Okay, sir. Yes.
Smoking has got any importance here?
Yes, sir. Carcinoma, it could cause mouth cancer,
Mainly, that's
oral cancer,
mainly oropharyngeal
oral
carcinoma.
cancer.
So
Or
Yes, sir.
definitely it is
pharynx.
Yes, sir.
significant, very significant.
Hmm.
Okay. So detail one packet per day. You have already mentioned how much
Yes,
it
sir.
is. One packet
And
it is.
as oral hygiene also could
Okay.
affect.
Okay.
Okay.
Next slide. Okay. This summary. So before summary, Kishan, you want to add on to anything, Kishan?
No, no, sir. I will go on, sir. Already
Okay.
Robin sir has
Ask
asked
any
whatever I
question,
wanted to.
anything, please ask. You can ask Vijay. Uh,
Sure,
about
sir.
summary, Robin, you are okay with their putting possible diagnosis with the lymphoma?
Yeah. Yes, sir. Definitely.
Okay.
Yes, Kishan. I think Kishan, you also agree with sir also, na? Because most common differential diagnosis for a lymph node enlargement, what they've shown here is cervical lymph nodes, TB, and lymphoma.
Lymphoma. That's what
Correct, sir.
they have
Correct.
Yes.
Yes.
mentioned. There are three things.
Secondaries, three things.
All students should remember three conditions:
Three
tuberculosis,
L's. Yeah.
secondary, and lymphoma. That is the thing
Lymphoma.
more interesting and more relevant for us to diagnose and manage all those things. So these three conditions are most important and likely have a possible diagnosis. So that's why but it is that's mentioning is accepted, not issue. So we'll go to next examination, Robin.
Yes, sir. Yes.
Okay, okay. So this is uh, Mega. Continue.
Yes, sir. So good evening, everyone. So I'll be continuing the examination part of this presentation. So general physical examination. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is moderately built and adequately nourished. Height is 166 centimeter, weight is 58 kg, and BMI is 21.3. Vitals pulse rate is 72 beats per minute, which is normal rate, regular rhythm, normal volume and character, and condition of vessel wall is normal. No radial delay. Blood pressure is 128 by 76 mm of mercury in right arm sitting position. Next slide. Respiratory rate is 15 cycles per minute. Temperature, he was afebrile at the time of examination. And there is no signs of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and edema. Next slide. Now coming to the local examination. On inspection, a solitary swelling is present over the left side of neck, horizontally oval in shape, appears to be 8 into 10 centimeter in size, extending from 2 centimeter anterior to sternocleidomastoid anteriorly to the posterior triangle posteriorly, and from superiorly 3 centimeter below the ear lobule to inferiorly 2 centimeter above the medial one third of the clavicle. An ulcer is present on lower aspect of swelling that appears to be 2 into 2 centimeter in size with well-defined regular margins, sloping edge, floor containing granulation tissue with serous discharge. Dilated veins seen on lower aspect of the swelling anteriorly. There is no scar present. There is no movement of swelling with deglutition. Next slide. On palpation, local rise of temperature present over the swelling, tenderness present over the swelling, a solitary swelling is present, horizontally oval in shape, measuring 8 into 11 centimeter, extending from 2 centimeter anterior to sternocleidomastoid anteriorly to posterior triangle posteriorly, superiorly 3 centimeter below ear lobule to 2 centimeter above medial one third of clavicle. It is confirmed. Surface is nodular, margins are well defined and irregular. Consistency is hard over mainly areas and soft over few areas. Mobility, it is immobile and there is no pulsatility. Skin is pinchable over few areas and not on other areas of the swelling. Other relevant examination, there is no deviation of tongue towards the affected side. Patient is able to shrug shoulder normally. There is no drooping of eyelids. Movement of neck towards the side of swelling is restricted. Trachea is deviated towards right side. Superficial temporal artery and maxillary artery pulsation is felt. Laryngeal crepitation is felt. Cervical spine, there is no tenderness or deformity. Next slide. Now neck lymph node examination. Level 2, 3, 5 and part of 4 cervical lymph nodes are enlarged on left side. Next. Oral cavity examination. Mouth opening is not adequate. Trismus is present. It is less than 2 finger breadth. Oral hygiene is not maintained. Submucosal fibrosis is felt over the side of angle of mouth. No ulcer, swelling over lip, vestibule, tongue, tonsil, palate, and floor of mouth. Tonsillar fossa is normal. Dentition is on left side, upper half, it is 2110, right side 0101, and on the lower jaw it is left side 0202 and right side 1021. Next slide. Other lymph node examination, there is no enlargement of axillary, paraaortic, iliac, epitrochlear, inguinal or popliteal lymph node. Next slide. Systemic examination per abdomen, it is soft, non-tender, no organomegaly. Cardiovascular system, S1 is to heart, heard, no murmurs. Respiratory system, normal vesicular breath sounds heard, no added sounds. Central nervous system, no focal neurological deficit is there. On skeletal examination, there is no bony tenderness over skull, cervical, thoracic, lumbar, sacral, sternum, ribs, and iliac crest. Next slide. So summary is a 55-year-old male patient presented with chief complaints of swelling over left side of neck since 4 months, which is hard, nodular, tender, and immobile with well-defined margins, approximately 8 into 11 centimeter in size. An ulcer is present over the lower aspect of swelling with serous discharge. Neck movement is restricted towards the side of the swelling. Next slide. My provisional diagnosis is secondaries in cervical lymph node on left side of neck with clinically unknown primary, and the differential diagnosis is tuberculous lymphadenitis, lymphoma, HIV infection, and non-specific lymphadenitis.
This part we will discuss later. That's later. Shreya, go to first slide. Photo slide.
Inspection. Yeah.
We just see the photo first. Okay.
Okay.
Robin, you can have put some comments with that because whatever any mistakes or anything, just have a look and then we'll go to the question. We'll go to the next slide.
Megha, the main site, what you have mentioned on inspection, which is the main site of the swelling? You have given a perfect, it's very good. It's very good. It's just that extent of the swelling from anterior border of sternocleidomastoid to
the photo, Shreya, back.
Yeah.
Photo.
Yes, it is mainly on the lateral side of the neck, which
that's the thing. It's actually,
and,
the sternocleidomastoid is very clear. It's actually not here. It's away.
Yes.
You can see it from there, no? And
Yes,
one
sir,
more
but
thing,
yes.
we can see an ulcer. I'm sorry to interject. It's just that ulcer we can see. What is the swelling beneath the ulcer? Are there two? Are there two swellings?
No, sir, this is nodular.
Okay.
Surface
This one,
is nodular, sir.
Surface is nodular. So, matlab, this is not a separate swelling. So
No,
it's
sir,
like
it is nodular.
it's like a bossulated swelling.
Yes, sir.
So okay. Fine.
Hmm.
Okay.
Skin changes are there, Megha?
Uh, yes, sir. Little bit skin changes are there. Near ulcer, it is hyperpigmentation is there,
And
and
some redness is there. Is it this
redness is
granulation
there.
tissue is healthy or unhealthy?
Sir, it's a pink granulation tissue is present, so it's kind of healthy.
This is there is a lot of fluff is there, no? This is unhealthy
Yes, the
granulation tissue.
yellow slough is also there, sir.
What is fluff? Define fluff, Megha.
Sir, it is formed on the surface of ulcer due to uh,
Define it. Ajay, can you define fluff?
Mm,
It is a
Not sure.
it's a dead soft tissue in situ.
It's
hmm,
Okay? Dead soft tissue in situ. That is the definition of the fluff. SLOUGH. Okay. So share next slide. Okay. Next slide.
Mega, you mentioned
yes, sir.
something about no radial delay. Can you
Pardon?
give us few differential diagnoses for radial delay? Is it actually relevant in this case? No, but just
Uh,
give us some differential. You have done
what do you
you have
wanted?
done very well. Just if you can give us two or something. Any
Sir, if it is so if radial artery is affected in case, then
So how radial art is affected here in the next slide?
how how will the blood? Yeah.
not here, sir.
Not here. Okay. In case if it is very low swelling, if it is subclavian artery is involved, then pulsation will be weak. In such situation, maybe
Yes,
otherwise may not be much relevant because you will invite
Yeah.
unnecessary
Questions.
questions in the exam. Then they will ask what are
sir.
the then you will maybe divide it to the medical side also. What are the causes?
Yes,
Then
that
may
is the
not
reason
come
I
in the
asked
exam.
you. It has no relation to this case.
This case.
So because you have presented so well that I thought I'll ask you something out
Yeah,
of the
that's
norm.
what. So
But
you should
Yes,
be able to
sir.
so
give reason for whatever you are telling, whatever you are writing. That is the
Yes, sir.
clinical surgery, no?
Yes,
So
sir.
say go back to the previous slide. So that radio radial delay will really trouble you. So in surgery, unnecessary things should not tell unless it is you are asked for. Correct, no, Robin?
Yes, sir.
So
yes, unless
otherwise,
a peripheral vascular occlusive disease, fine. You
Yes,
can put
sir.
as a radio femoral delay, but please, like Sir has said, you have to be ready to justify. There are four
Yes, sir.
causes for radial delay. Please read it up. I will give you
yes,
one. The rest three you read. Takayasu's
yes,
arthritis
Yes.
is one.
Take care, sir.
There
okay.
are four
There
for
are four
radial
causes.
delays, and
Yes.
Sir has already given you clues, something to do with this area only.
This area only.
Subclavian artery. Yes, sir.
Subclavian.
Okay, so other causes you find out and put it in the message. Okay, so
Yeah.
everybody will come to know. Okay, so unnecessary things. So morally, unnecessary things don't add. It will unnecessarily
Yes,
invite
exactly.
questions, and entire thing will get annoyed you. Okay, so that's very important. What is relevant only you have to put. Okay, so next slide. Yeah, next slide. So Robin, here
Mega, the swelling is correct. Everything is fine. You have given just for the revision of all the students listening. Skin over the swelling, sir has pointed out very well because that is very important on inspection, which we confirm on palpation. Everything
Yes, sir.
around it. So, sir has mentioned about the discoloration. He asked you what it is for. I would like to know. He specifically asked why is that ulcer having that slough? How did that form? How come the swelling down didn't form at that?
Sir, ulcer is formed in neck swelling because of tumor necrosis. If it is secondary in neck, so if
Absolutely.
you
No, that's it. That's it. Just keep it very simple. Absolutely right. When you have a very
yes,
large swelling, what happens is that necrosis. Where does the necrosis happen?
sir, it is in skin and soft
No,
tissues.
where? No, where the skin is a soft tissue. Where do you find it in that region? Why did that portion
why it is
undergo necrosis?
which you have to use a more specific word. What part of
Because
the
on
swelling goes for a
yes,
necrosis?
because on palpation, you will be confirming this finding, right? On
Yes, sir.
inspection findings are confirmed. So you will feel for something there, and you actually mentioned it very well also.
So it occurs over the summit, okay, usually.
The center of the thing. So because slowly it becomes very soft there, and from there periphery it becomes. It's there in
Yes, sir.
all the books. Yeah, sir, it's there in sir's book also. You just have to read it by heart. So that's one thing. That's very good. And well-defined regular margin, sloping edges, and floor that contains granulation tissue. Now you did not mention. Sir has asked what type of granulation tissue. So skin over the swelling. Yes, you have mentioned everything about that and the margins of it. Everything. That the ulcer is the main finding there. Something about the
Yes, sir.
swelling beneath also the extent and everything is correct. So in ulcer, skin around it, edge, margin, floor, base. So two on inspection, two on palpation. And the floor is on inspection, but what type of granulation tissue? Healthy, unhealthy, slough.
So
So I
it is
think,
unhealthy granulation
yeah,
tissue is there.
right. So in an unhealthy granulation tissue, will you find serous discharge?
So there was serious discharge. So it's for dripping also.
Yes. So what the thing is basically when you see the picture, you will find out that there are different edges to that ulcer. You
Yes, sir.
have well-defined regular margin with sloping edge, which is probably like you said, it's healing on some portion, and the other portion is
Hmm.
having slough also. So that's unhealthy.
Yes, sir.
That's why you have both serosanguinous discharges in both. Yes. Dilated veins seen on the lower aspect is reason is why
Why dilated veins?
simple.
So mainly dilated veins are mainly due to, sir, mediastinal compression due to tumor.
So no tumor. It's a very early word to use. I think so. Probably because of the size of the swelling, it has caused
Size
the
of swelling.
dilatation.
Yes,
Yes.
sir.
Yes.
Yes, sir.
No scars present. Are you expecting some scars there? Any
Sir,
condition where you expect some?
if biopsy or
So
anything has
incision
done,
and drainage
any
or
Yeah,
incision and
yes.
drainage is
You
incision
have
done.
and
you
drainage.
have done you have done a simple FNAC probably. The first classic thing that
Yes,
you do
sir.
for any swelling in the body is an FNAC. One,
FNAC, yes, sir.
two, like Ajay has said, incision and drainage. Probably the whoever thought was an abscess has drained it,
Hmm.
Yes,
right?
sir.
So scar is there. Fine. What if there was a scar there and it is continuously discharging something?
What it means?
What would your differential diagnosis be? I will try to be a bit more
So
specific.
it could
You
be
have the sternocleidomastoid here. Okay, what are the differential diagnosis in these portions that can cause a continuous discharging, a swelling that you have
so
inadvertently tried to
tuberculous
treat?
lymphadenitis. It could be so.
In the anterior portion of
And
sternocleidomastoid,
any other
And
thing? Any other relevant, much more relevant thing?
the triangle is
anterior.
different. Anterior border.
Okay.
That is the
Any other?
simplest clue I can we can give you.
Any other thing to have a discharge?
There are two swellings here, one swelling here, and one swelling here. Two of them are congenital here. One is not congenital; it's almost an acquired one, and the other one last is also
Branchial
acquired.
cyst,
Branchial cyst.
Branchial cyst.
branchial cyst,
It's a
Branchial cyst.
branchial
brachial, not a
fistula,
brachial cyst,
Right.
a
and branchial
Hmm.
fistula.
fistula,
You have
sir.
adverted and you have a fistula.
Yes,
So
sir.
your
Fistula.
figure, the catch is if you tilt the face, the sternocleidomastoid is stretched in such a form that your swelling is here and your ulcer is here.
And
So
this
Yes,
the
sir.
only
dilated
reason I asked is
veins,
that just so that
uh,
that's the upper portion of the neck
you have to
because
remember.
it's near, like you said, lateral to posterior lateral. It's
And
somewhere here.
Hmm.
The
Yes, sir.
most common area for a TB lymph node, most common site.
Yes, sir.
what is the site? Tuberculous lymphadenitis. Which in the neck? Which triangle it is common?
Most common site.
Sir,
Which triangle?
of
So posterior
Posterior
triangle.
triangle
triangle.
posterior.
Posterior triangle.
It is
Another
a
thing,
posterior triangle. Yes. Yeah.
Yes,
dilated veins may be due to the vascularity,
yes,
inflammation,
sir.
and
Increased vascularity, sir.
it is not the mediastinum because lower border is seen. It is a high up swelling, no. So I will enter
Yes,
the
sir.
mediastinum. So
Yes.
Yes. Yeah.
so
Because you can
and
literally see the
simply
lower
due to
border. No?
vascularity and due to
Yes,
inflammation,
sir.
dilated
Yes, sir.
veins.
Yes.
You put it a
You can see
simpler
the
word.
hollow. Yes.
Yes, sir.
So
And there is no movement of swelling with deglutition. I
yeah,
want to digress on this with Mega. I am not very happy with that sentence.
why you
Can
want
you
to
tell
push
us
He
it?
has,
why?
Justify here. You justify why
so
you want to
because
push.
it is mainly thyroid swelling thing. Because in thyroid swelling,
No,
we
Mega, thyroid swellings are not the only ones that move with deglutition. I'm sure you know
yes,
that.
sir. Yes, sir.
There are other
Thyroid
swellings
swelling
also, but
also will move
Yes.
with
yeah.
deglutition.
Yes, sir.
So why you want to check for a movement of deglutition in either thyroid? Can you give some justification? We are totally this whether relevant or irrelevant is a debate, and you are not totally against, but you justify. If you have written something, you should justify. Understood? No, you should give you reason why you want to look for. That may be primary in the thyroid, it may be secondary. It's the one aspect, or this it will maybe thyroid. If you answer like that, that is the reason I have looked for. Okay, right.
Yes.
So you will go to the next slide, Robin.
Yes, sir.
Palpation. Robin,
Yes, sir. Local rise of temperature present over the swelling. Okay. What are the differential diagnoses for local rise of temperature over the swelling here and tenderness in this?
So non-specific lymphadenitis, any bacterial infection like streptococcal,
so
and
you think this is the non-specific lymphadenitis? Always only non-specific lymphadenitis will have the local rise of temperature.
No, sir. Any inflammation,
inflammation is
any
there.
inflammation,
TB lymphadenitis also,
TB
sir.
lymphadenopathy.
In vascularity, in tumor also it will have tumor
Yes.
necrosis,
Yes, a tumor also.
response
Yes,
there, and over that tumor itself can be vascular and have the rise of temperature. Okay.
yes, sir.
Yes. And you mentioned the rest is okay. Consistency is absolutely right because we can even see from the figure that some of the lower portion is hard, probably firm to hard, and few areas are soft, which is ulcerated because of the necrosis
Yes,
tissue.
sir.
You mentioned mobility; it's immobile.
Yes, sir.
Mobile. So it's fixed to what?
How did you? Yeah.
Sir, the swelling, I tried to fix the swelling and then I tried to move it. So it was immobile. It is mainly due to fixation of the swelling to prevertebral fascia.
Reverse vertebral fascia. Okay, how did you fix it? How did you fix the? How did you check for it? You said you fixed it and you tried to move it. Now, how what? How
Yes,
did you fix it?
Is it absolutely non-mobile or is there any mobility in that?
sir, it is absolutely non-mobile, sir.
Okay. Is it if it is mobile, if it is adherent to the sternocleidomastoid muscle only, what will be the mobility?
Will be
So it will be
restricted.
mobile in line with sternocleidomastoid, sir.
In line or horizontal with the sternocleidomastoid muscle?
Horizontal,
Or
horizontal.
What will happen to the mobility when you contract the sternocleidomastoid muscle?
What, sir?
What will happen when you contract the sternocleidomastoid muscle? Key muscle in the neck is sternocleidomastoid muscle. Am I right?
Yes, sir.
So
Yes,
you have
sir.
to always check any swelling in relation to sternocleidomastoid muscle. So this is absolutely not mobile accepted. So naturally we presume that
so when we contract the muscle, the mobility will decrease, sir.
what?
Contract the muscle, the
Okay,
mobility will reduce.
a little restricted. That is right.
Yes, sir.
Yes, sir.
What about skin? You said skin is free or non-pinchable?
Sir, at few areas, like anterior part of the swelling, the skin was pinchable, still pinchable, but in the middle part and posterior part of the swelling, skin was not pinchable.
Not pinchable. Okay.
Yes.
So
Why?
you do this. You make the sternocleidomastoid firm by doing the chin test or one side, and you make it prominent, and you look for the mobility along the fibers and at right angles. Yes. So
Yes,
yeah,
sir.
okay, fine.
Why pulsatility? You
Pulse,
said?
pulsatility.
So pulsatility because of carotid artery invasion maybe, and a carotid body tumor is pulsatile,
Okay.
carotid
Yes.
aneurysm is pulsatile.
Yes. Mega. Very good. Yes. Very good. But I have to again digress here. I am not very happy with that. Where is the location of the carotid artery? Where is the carotid sheath? Where is your swelling? Where is your ulcer? Which
Yes, the
triangle?
carotid sheath is in front of neck, and
Yes,
here it is
it's
in the
the
lateral side.
yeah, the whole triangle is divided into simple forms, midline and lateral. And
Yes, sir.
anatomically, we have the anterior triangle and the posterior triangle based on the sternocleidomastoid. We have four triangles in the anterior portion, of which
Yes,
one
sir.
is the carotid, which is in front of this. So your ulcer and swellings are here.
Yes,
So
sir.
supposing, hypothetically speaking, there was pulsatility, what sort of pulsation would you have got in this case?
Suppose it
Uh,
will answer because they're extending for far anteriorly also. That is a low.
Transmitted type of pulsatility.
Yes,
Okay.
yes, that's the only. It would be a transmitted pulsation. If it was from the vessel, it would have been expansile. You're right.
Yes, sir.
You have carotid artery aneurysm and you have a carotid body tumor. Two differential
Yes, sir.
diagnoses for expansile pulsations. Yes, very good.
Yes, sir.
So
Okay.
Next slide, Shreya. Okay. Why deviation of the tongue towards the affected side you wanted to check?
Sir, if hypoglossal nerve is affected, then there will be deviation of tongue towards the same side.
Towards the side of whichever the lesion is. Very
Yes,
good.
sir.
That is one finding. What is the second finding that you will get on examination?
What the second finding you look for? Ask the patient.
Don't touch. Just on inspection, what will you see?
Only look for the deviation or something is called as what? It is called as
Upper
what?
1/3.
Yeah, there is a name for that point because all nerves come through that area. What is that
Yes,
point
sir.
called as? Do you know any name for that?
No, sir.
Ajay?
No, sir.
That point is called as Erb's point. It's a different Erb's point from the brachial plexus.
Yes.
That's a different thing.
Yes, sir.
The Erb's point in the neck where all nerves come forward, anterior rotator nerve and greater auricular nerve, supraclavicular nerve, and the deeper plane, spinal accessory nerve. So
Yes.
this particular point is called as Erb's point. Okay,
Yes.
that's why you have to look for. Agreed. Why drooping of the eyelid?
Sir, Horner syndrome can be there due to sympathetic chain if it got affected.
Okay, why? Which
So involvement of the which sympathetic chain? Sir was asking.
So superior.
cervical sympathetic chain? Okay.
Cervical
Yes, sir.
sympathetic
Cervical.
chain. That's all.
Yes, sir. Yes, sir.
Ajay, what are the components of the Horner syndrome?
Sir, Horner syndrome.
Components
Four, I
of
am
There's
sure.
toes.
Yes,
There are
sir.
5. I am
Yes,
sure
sir.
you will tell 4. The fifth one might be difficult.
Sir, there is a loss of spinociliary reflex.
Oh, I thought you will not say that, but you said that, unfortunately.
That's the last thing to be told. Before that,
That is the last one.
Yes, sir.
That is the loss of ciliary spine. That is the last one, like sir
Yes,
said.
sir.
Yes. Okay.
And
So the rest should be easy.
meiosis.
Yeah.
Meiosis is seen.
Meiosis.
Okay.
Yes.
Then the
Other thing, you should be
Ptosis.
in your finger.
Sir, ptosis, endophthalmos,
ptosis.
Pseudotosis.
pseudotosis. Yes, sir.
Pseudotosis.
Pseudotosis, endophthalmos,
End of.
Enophthalmos.
and hydrosis.
And hydrosis. Yeah. Okay.
Okay.
Yes,
Loss of the cervical sympathetic chain because Horner syndrome, all of them. Yes, very good. Yes.
yes, sir.
Why did you mention trachea is deviated towards the right side? Is it that big a swelling that has caused a whole shift?
So that swelling is not extended anteriorly that much, but there was significant shift of trachea towards right side. On examination, I find out, sir. I mentioned, sir.
So why it
How
is
did
so?
you how did you figure it? How did you figure out that tracheal shift?
Why it is so? Why?
Sir, I did the 3-finger test, keeping
Okay.
to index and ring finger on the clavicle, anterior clavicle, and the middle finger I run through the trachea. So checking the gaps between the sternocleidomastoid and the trachea, it was less on the right side and more on the left side. So there was
That's right. Absolutely
significant
wrong. What
shift.
if Professor Robin is asking is how you think why it has happened. He's asking why it has happened.
Sir, tumor has pushed the organ towards right because tumor is on the left side. So might be like shifting of trachea towards right.
Okay.
Okay. What do you call that sign, which you have beautifully told us? What do you
There is
call
a name
this?
for that.
Where you run your finger this way and you find some deviation.
Deviation. What is that sign called?
What do you call it?
Any name for the? Usually we use that one in thyroid swelling.
It's a very simple English word if you can use. If you know, if your finger is running away, what do you call it?
Not sure.
Sir, don't know, sir.
Not
Or might not remembering right now.
Okay. It's called trail sign, no, Robin?
Trail
Trail sign, yes,
trail
sir.
sign, trail sign.
Yes, sir. Trail sign.
That's how we
You
have
are
to clue. Your finger is
You
leaving
are-
away like that. So
your finger is trailing away.
trailing away.
Yeah.
That's a word. Trail is a word.
Trail sign.
That meaning.
Yes, a trail
Yeah.
sign positive.
Yes.
So, Robin, interestingly, she has told maxillary artery. So, I don't know how she accounted for that.
I wanted to catch that, but sir has caught it actually. I want to know how she has figured out that one. Yeah. So was it temporal? Okay. Even the textbook says super, but how did you figure out the maxillary artery?
Sir, I felt pulsation at the angle of mandible, sir. So near the angle of mandible.
That is facial artery, no?
Yes, sir.
This-
Yape.
this-
Maxillary
this-
artery,
this-
yape.
No,
Facial
no,
artery.
that's his facial artery. Yes, sir.
So either by maxillary artery, usually I don't think any books are mentioned, and they usually won't be able to feel it. Rather,
So it is near the angle of mouth usually.
that is a
Maxillary
terminal
artery.
branch. I don't know.
Yes, yes. Facial artery, fine. We absolutely agree. Maxillary artery. It's like a very rare finding. I've not heard a postgraduate also mention
I
it.
don't know where
So
you got it. Nobody's usually mentioned. So you better not write.
Okay, okay,
Yes,
sir.
sir.
Stick yourself to the superficial temporal artery and be happy. Don't add,
Yes, sir.
you will be unnecessarily in trouble. Okay.
Yes, sir.
So about
Yes,
that.
sir.
So
Yes.
laryngeal crepitus, why you wanted to check?
Sir, if there is laryngeal carcinoma, then laryngeal capitis will not be felt.
Normally it is felt or not. When you are
Yes, sir. Normally, in every person, it is felt.
okay. So I will check for that.
Sir, we will hold the larynx like this in front of the neck, and then we will move it horizontally, and there will be a grating feeling is there. So that is the laryngeal crepitus.
Okay. Cervical
okay.
spine, why you want, Robin?
Sir, because if it is TB, because of TB, then POTS abscess can be there in the prevertebral space. So there might be the spinal tenderness is there or some deformity is there.
Cervical spine. Okay.
Okay.
Yes, sir.
So next slide, Robin. Next slide.
So basically, all the cranial nerves, 3, 4, 5, 3, all the way to 7, 11. Yes, very good. 12, including spinal accessory, you have covered here. Yes, very good. You have completed the whole checklist of history taking, physical examination, including the cranial nerves, oral cavity. In a case of lymph node, just simply a quick summary for the ones who are listening. You have to cover the head and neck completely, which includes the oral cavity. I have a small complaint, Mega, but otherwise it's very good. What about the salivary glands?
Yes, sir.
What about salivary gland?
Uh,
Are
yes,
the
sir.
salivary glands not
Then
part of our lymph
Salivary
submandibular.
gland.
nodes?
Yes, sir, they are part of
Yes,
that.
sir. We have to.
Which are they? Which are the ones that is there in the checklist that you have
Submandibular
to?
lymph nodes, sir.
Yes,
Salivary gland.
submandibular
Gland.
gland, and
Subman and
and
Low,
Salivary gland.
lower part
link,
of parotid.
lower
yes,
part
very
of the
good. Yes,
Lower
parotid.
Ajay.
part of the parotid.
It is a tail of the parotid and the
Yeah.
submandibular gland. Yes,
Salivary
very good,
gland.
Ajay. Yes, yes, very good.
Yes, sir.
Yes.
Okay, levels you have mentioned level 2, 3, 5, 4. Okay, agreed. Which levels you are specifying? What these levels are called as? What name? Stone Kettering levels. You know that name, no?
Yes, sir.
Okay. So next slide. This is where it is the oral cavity examination. Why Christmas this patient is having?
Sir, infiltration of buccal muscles, like
Which
fascicular muscle.
this swelling is infiltrating buccal muscle?
Sir, yes, submucosal fibrose is present, so
Oh, okay.
it will
Yes, sir.
restrict the.
Okay. Other things you have mentioned: lip, vestibule, tongue, tonsils, palate, floor of the mouth. All those things you have mentioned. But submucosal fibrosis, probably that is the cause. Oral hygiene not maintained.
Yes, sir.
Dentition you have mentioned, good everything. But you have history-wise you have mentioned the loose teeth. But on examination you have never mentioned about that. One it's very relevant, no? There may be a
Yes.
proliferative ulcer in the near the loose teeth in the gingiva.
No, sir, there was no
No,
any
sir.
ulceration in buccal mucosa or any like
But you
tonsillar
should have
bed.
mentioned that specifically because you said having said that history-wise there is a loose teeth, no? Loose tooth is there. You have mentioned.
Yes, sir.
Okay, we
Okay.
thought
Yes.
that may be the focus, primary focus. That's why you mentioned that nothing, no ulcer in relation to the loose tooth. Okay, so that you have mentioned. You have mentioned, I think, but we are not specifically mentioned in the loose tooth. Okay,
Yes, sir.
so anything else here, Robin?
No, so correct. The oral cavity is fine. She's mentioned everything about the dentition. Fine. Tonsillar fossa, very good because that is very important when it comes to the neck.
Okay.
Mega, just a
Yes,
theoretical question. Now you have seen the oral cavity, so basically it's the oropharynx. What
yes.
are the spaces that are important in neck secondaries?
Sir, pyriform fossa of
S-
Rosenmuller,
No, no, spaces,
okay.
anatomical spaces that are important. Yeah.
Paranasal sinuses.
Paranasal.
Paranasal sinuses are not a space per
Base
se.
is
Like
not a
we are
space.
in.
Maxillary sinuses
Yeah.
mostly, like maxillary
So
sinuses.
sinus, okay, you have to look for sinus, ear, nostril, nasal cavity for
That's
primary.
all fine. Yeah.
That's agreed. But
Okay, nasopharynx, oropharynx, laryngopharynx.
Right.
These are important.
No, those are parts of the pharynx that you are telling us. So we are looking for
they are not
spaces
ever,
where, yeah,
yeah, inferior
there
superior
are,
cases. Yeah.
there are a few recesses, two spaces, parapharyngeal, retropharyngeal. I'm sure
Yes,
you've
sir.
heard of this.
Yes, sir. Yes, sir.
Yes, sir.
Parapharyngeal and
It's very
retropharyngeal.
important because like Megha was, like shooting over the gun. So she wanted to take biopsies of Fosa Rosa everything. So this is all in that. You're right.
Yes,
Yes.
sir. Yes,
It's a
sir.
Yes,
simple
sir.
thing. Two spaces. Yes.
Okay.
Yes.
Next,
Yeah. Fine. Fine, sir. Yeah. Floor of mouth. Yes.
rule of the most other things are shared. Posterior third of the
Uh,
tongue
uh,
examination, they may be asked.
yes.
I think you'll be knowing. Next slide.
Yes.
Yes.
Prayer, next slide. Other lymph nodes examination, epitrochlear. Okay. Why you wanted to examine other lymph nodes? Important. Why?
Sir, to rule out lymphoma, sir.
Okay. 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 Great. Next slide. Okay. Anything to this? Any question to this, Robin? Is it
Uh,
okay?
Systemic examination is fine, sir. No problem.
That's fine.
So
Okay.
there are two questions. I'll just by the time answer it in the this thing. I'll just finish it up. Name of.
Okay.
Yes, sir. We can proceed. Yes, no problems.
Okay. Next one. Next one. Next slide, Shreya. Okay, summary, an ulcer present over the lower aspect swelling, discharge, the neck movement restricted. So the research summary is okay, that is good, looks okay, that is perfect. Okay, so summary, again, we have been telling all students because last session also you were told, after history you have to put summary, after complete examination also you have to put summary. There is a proper
Yes.
writing technique in surgical side at least. In most of us expect, most of the exams expect that don't violate this rule which is required. Okay, after history summary and after complete exam summary, like what I have written today, that is relevant in every college, anywhere, or surgical site. When you present a long case, this should be the absolute proper method. Okay, so next slide. So diagnosis, yeah, Mega.
Yes, sir.
Tell me.
Uh, oh, I should read, sir.
Yeah, I should read.
Provisional diagnosis is secondary in cervical lymph node on left side of neck with clinically unknown primary.
Wait,
Differential
wait.
yes.
Now, why you said secondaries?
So usually in this part of the neck, secondary is common.
But lymphoma
And
also can occur, no?
yes, sir. But sir, on examination, there is no generalized lymphadenopathy.
Not necessary, no. Stage 1 only neck lymph nodes can be involved.
And
Not
sir,
The
in
swelling is hard.
lymphoma, the surface is smooth and there is India rubber
what
consistency.
is the feature here, you tell?
Yes, sir.
Why you said secondary specifically? On what examination made you to
Sir,
think
it is hard and nodular, sir. This
hard,
Yes,
swelling was
hard
hard and
and
nodular.
nodular.
And
nodular, muscle, subnuclear mustard infiltration is there,
Yes,
infiltration.
Fixity.
is there.
Fixity.
fixity is
So,
there.
all those
Fixity is
Tumor
there.
necrosis is there.
and lymphoma is usually smooth, firm or India rubber consistency, usually
Yes.
mobile, and
Yes, sir.
fixity is uncommon. Understood?
Yes,
That's the
sir.
difference. Occasionally, it can occur in NHL. I have seen NHL presenting with the fixity and ulceration. That's a different thing. But by and large, clinically, usually firm, smooth, India rubber consistency, mobility. Okay.
Yes, sir.
So that's why this is. So you should be able to give clinical reason why you are thinking that. So
Yes.
surface,
Sir,
nodular,
I have a doubt, sir.
immobility, things are the features. Okay.
Sir, fixity is seen more in Hodgkin's lymphoma or the.
Secondaries, not Hodgkin's. Hodgkin's only
Yes,
like not secondaries is more common to get fixed
Yes.
than lymphoma. Okay, lymphoma no.
Yes.
Okay, so why you thought
Megha, why did you
Yes,
write
sir.
clinically unknown primary?
Sir, because on clinical examination of oral cavity neck, so there is I was not able to find any primary site of the
Okay.
tumor, sir. Usually oral cavity cancer is involved, and if not, then esophagus, laryngeal cancer, all
No,
these
no, no,
may
no.
be involved.
We that is you're going too much into theory. Your working diagnosis, your provisional is neck secondaries. Agreed.
Yes,
We
sir.
all agree with an ulcer. Yes. Now, when we divide that, we have neck secondaries with non-primary,
Non
neck
primary.
secondaries with clinically unknown primary, and next secondaries with the very famous one, that
Occult.
is occult primary.
Occult primary.
Agreed. We absolutely
Yes, sir.
agree. But the thing is, clinically unknown primary, matlab, you are saying oral cavity, which is the only thing you have mentioned. You said level 2, 3, 4, 5.
Yes, sir.
All these guys are involved, na? The
Yes, sir.
classification. Yeah.
Yes,
So
sir.
then again, you said esophagus and all that, but that you cannot make out, na? We have to
Clinically
investigate.
Sir,
unknown.
on history, if dysphagia was there.
Dysphagia was
No.
not there.
No
No, sir.
dysphagias.
No
No,
dysphagia.
sir. If
Oh,
dysphagia was there, then it might be esophagus cancer.
that is not right. Mega, that is, I think it is
So,
accepted clinically unknown primary. Clinically, you
Yes.
could not
yeah.
find out. Okay.
Yes,
Yeah,
sir.
that's
No
it.
evidence.
It may become a occult or become a revealed primary after
Yes, sir.
proper
Late,
evaluation.
Investigation.
later.
That is absolutely right, accepted. But your
Yes.
justification be why you have put the secondaries as a first possibility. That is more important. You should be able to give reason. So short duration, no, progressive, hard nodularity with the ulceration, fixity. That is more towards the
Secondary.
secondaries rather than lymphoma and tuberculosis. Still, it could be. That's why you have to keep always three conditions in mind when you think there is a neck lymph nodes. Okay.
Yes,
So
sir.
that's why you put the differential in tuberculosis, lymphoma. This HIV infection possibility, usually it is associated with the tuberculosis, lymphoma, or secondaries. It is association rather than independent presentation like that. Still can be. Then non-specific, Robin has to comment on that in this patient, non-specific
In
lymphadenitis.
this particular patient, I don't non-specific lymphadenitis
It's less likely, sir.
It's
less likely. So it's quite clear actually. It's either a TB lymphitis differential diagnosis, fine.
Yes, sir.
Lymphoma, fine. Yeah,
Yes, sir.
that's it.
Yes.
This is the most common two differential diagnosis. HIV infection, like Sir said, is usually adjunct to probably to a TB patient.
Tuberculosis.
Non-specific, there's
Yes.
so many bacterial, viral, parasitic,
but
fungal.
non-specific
So
lymphadenitis is very less
it's a
likely.
very it's a very vague term because usually the reasons to say that it's a next secondary male gender, the gender of the patient, then like we already discussed, there's something about the node. It is firm to hard, fixity. This
Yes,
many
sir.
things is more than enough to say
Mobility.
that
It
yeah
is secondaries. Right.
secondaries.
So this is the difference that why should be able to give justify. That is fair enough for undergraduate. We should be able to these things, I think. So next slide. So how will manage? Next slide, Saya. So how will manage without secondaries? So how will evaluate the patient?
Yes, sir. For evaluation, first we'll do certain investigation. So FNAC of the secondary, blind biopsy for primary, triple endoscopy, CT neck and chest or MRI, and X-ray chest.
Robin, you start commenting. I think.
Uh,
Comment rather
Mega,
than
it's very
asking.
nice. It's
Asking.
Ajay, your colleague has mentioned we have a plethora of investigations for this particular gentleman.
Yes, sir.
So,
Sir.
what is the most common investigation for any neck mass?
Most common, sir, you could do an FNAC, sir.
Yes, that's it. Absolutely right. We just for the sake of completion, we do a fine needle aspirating cytology, so we get
To
some
rule out
point of view of
malignancy.
second. That's all. We get secondary, then we look for the primary in some form, if at all there's something. Okay. She mentioned blind biopsy for primary.
Yes, sir.
What is the indication for blind biopsy, Ajay?
Sir, blind biopsies are done when we are not able to clinically and find out the primary. So, and through like we are not able to like find the primary.
Yeah, find the suspected where primary clinically not identified.
Primarily, we are
In
not able to
suspected
identify.
areas, you
So
take.
even other investigations.
So which areas you will take these blind biopsies?
So we could take it from fossa of Rosenmuller. We could or lateral wall of the pharynx, piriform fossa, or the tonsillar bed, or even the post cricoid region, and even larynx also larynx.
Okay.
Post cricoid
So
region.
basically, you have the tonsil,
Posterior,
tonsillar fossa, posterior third of the
tonsillar fossa.
tongue,
Posterior third.
fossa of
Posterior one third of the
Rosenmuller.
tongue.
Yeah,
Fossa of
fossa of
Rosenmuller.
Rosenmuller. Yeah, these are the main. Yeah, that's it. Yeah, subglottic region. Yeah.
Okay. What we meant by
What do you call? What is the other name for this blind biopsy?
Surveillance biopsy, sir.
Yes, it's also known as surveillance biopsy because you're not sure where it is. So,
Yes, sir.
supposing the FNAC fails, we go for something called blind. Now, after just before the blind biopsy primary, again it fails. What's the next step? Sir, I think sir, you have created a
Triple
PPT for diagnostic algorithm. SRB, sir?
Yeah, it
Sir,
is there in diagnostical. I have put,
oh, okay.
I have put it.
Sir,
Okay, diagnostic
triple,
algorithm.
yes, sir. Triple endoscopy is the next step, sir.
Do we need to do a triple endoscopy, or according to recent advances, there is something else?
So,
Because the drainage areas level 1 to level 7 chod do, but at least 6, huh?
Mainly
Yes,
it's
sir.
upper neck actually.
Yes, sir. CT
Upper
scan.
neck, yeah.
CT scan.
CT. No, that you have already mentioned. You've already
Yes.
mentioned that we are going for a pan endoscopy, which involves which are
Ha,
the things?
pan endoscopy. Yes.
and endoscopy.
Yeah. What are the components of a pan endoscopy?
Sir, laryngoscopy, bronchoscopy,
What laryngoscopy?
nasopharyngoscopy.
Are you going to go for a direct laryngoscopy or indirect laryngoscopy?
So both we can go.
Direct.
Why
Direct
Direct.
or indirect.
Direct.
Mainly direct.
Di-
direct
Mega,
laryngoscopy?
you fix to one, either direct and indirect both, or direct or indirect. What do you want?
Sir, direct.
You go for direct only. Yeah, you go for direct laryngoscopy. You go for the first
Direct
one
only
there. Second,
in these
yeah,
patients.
direct only.
Indirect will do
Second,
only see the vocal cord movement.
Second, esophagoscopy,
esophagoscopy,
bronchoscopy, nasopharyngoscopy.
nasopharyngoscopy. Okay, fine. So
Okay.
you will cover all the main drainage areas basically.
Yes, sir.
As we already know, I'm sure from Sir's book you have probably read this. It's very easy to remember
Yes,
also
sir.
the rule of
Yes.
Yes.
80. So you cover
Yes, sir.
all of them in that. All the guys that you see there are 80% malignant, and 80% of
Yes,
them
sir.
are in the upper portion of the head and neck above the level of the clavicle, supraclavicular region.
Yes,
Okay.
sir.
Yes. That includes the thyroid also. That's level, which is
Yeah,
thyroid is level what? Mega level 4, 5, 6, or 7. Thyroid malignancy.
Lateral neck nodes, so thyroid malignancy will know. In such situation, you have
Level
to
Which
cover
nodes?
thyroid also.
Sir,
Okay.
level 4, sir.
No.
3, 4.
No, not 3. 6. So level 6
6.
midline.
Oh, sorry, sir.
Central.
Anterior
Six.
cervical nodes
Yeah,
is the
level
6, sir.
So when you have the dissection, it's very easy to remember that. No, why do you call it the
Ha.
central compartment or the anterior
Yes, sir.
compartment when it comes to neck dissection?
Yes,
In
sir.
papillary carcinoma, we use the term central. When you come
Yes,
to
sir.
dissection, we call it anterior.
Yes.
Yeah, that's simple. Level 6. Yeah,
Yes,
level
sir.
7 is mediastinum. Yeah.
Why
Mediastinum.
X-ray chest?
When you have done
To
CT,
see,
why you want
sir.
X-ray chest?
See, why anyway you are doing CT chest, then X-ray chest is not much relevant. Okay. Anyway,
Yes, sir.
right. Ideally, this patient needs a PET CT because primary is not revealed properly.
Yes,
That's why
sir.
totally currently this patient a PET CT may be required. So we'll go for the treatment, Robin.
Yeah. Kishan, you're there?
Kishan, your comment anything about
On
Yes, sir. Yes,
investigation?
sir. I'm here. I'm there, sir. No,
Investigation, anything?
fine, sir. Fine, sir. Fine. Everything is fine, sir. Fine.
Because next secondaries is a very vast topic. So diagnostic
Yes, sir. Yes, sir.
algorithm, there are so many
I think,
questions to
yeah,
ask in
sir.
that.
Services, whatever that PPD is there, if you can
Yeah.
show us, it will be a benefit
Like-
for all the students and for us also.
Yes.
What is the
Which
whatever
one to
recent
go to?
updates
The
are there?
next, the steps. Yes.
Yes, yes.
Mega, please remember
But
there
for
are
sir,
4.
Robin
It's
sir,
pan
but for their
endoscopy. Yes.
Yes, sir.
exam, that recent updates they should tell, or whatever written in the books they have to tell for their exams.
Yeah, Kishan, that is a very good point. I think when we are both, I think we are all used to teaching postgraduates, so we get used to this system of, I think, saying everything. Yeah. Sir, I think you can comment on what Kishan has asked.
What exactly Kishan asked? Kishan,
The recent advances, matlab now, for instance, now FNAC is the first step that we go. If it's negative, what is the second step in the algorithm is the blind biopsy of that.
yeah,
If that's for the primary. Megha or Ajay, is there any role for biopsy? If the FNAC has failed, can we go for biopsy?
Sir,
So usually we should not do biopsy because it can cause spread of ulcer very fast, and there can be difficulty for management. If we are doing the biopsy, then it should be immediately sent to the pathology lab so that the frozen section can be taken.
Yes,
And if the
absolutely
result
right.
is
Yes.
positive, we have to perform the surgery then only.
Right.
Then and there itself. Yes, absolutely
Yes.
right.
In
Yes.
this patient, if FNA is negative, you are allowed to do biopsy because already advanced. We can do
Yes.
any biopsy from the ulcer. Deep biopsy
Yes.
from the ulcer edge will not cause any problem. additional problem will not occur in this patient. Otherwise, mobile lymph node secondaries without soft tissue involvement, without extension, we are not going to discuss about the end staging here, PMA, all those things, because when the extranodal extension is not there, such situation you should never do the open biopsy. Otherwise, this patient, if FNA is unlikely to be becomes negative, you can allow to do the open biopsy. Okay. So
Yes.
next is, of course, directly can go for a blind biopsy, triple endoscopy. These are the things are fair enough for UG level. Definitely, I think, Robin.
Yes, sir. Yes, sir. Yes, sir. You
Debate on
answered
that.
everything correctly. Yes, yes.
Definitely sufficient for UG level. Okay.
Yes, sir. Yes.
So treatment. Shreya, next slide.
Next slide. So for treatment, we will do a neoadjuvant chemoradiotherapy. Then we'll reassess by doing CT scan and give chemoradiotherapy if needed. And if the tumor has downstage, then we can perform radical neck dissection if it become mobile. And then we can do surveillance for primary every 6 months.
Okay, that is Robin. You have to comment on because.
So she has mentioned it correctly, but the problem with this next secondaries, it's very vast because there's so many things to
Yeah,
ask.
that's what. But
So
this patient,
for undergraduates, yes, sir.
this patient right away surgery is not at all possible because of fixed swelling. So
Yes.
neoadjuvant radiotherapy, if it is mobile, go ahead and do the radical neck resection. Then surveillance for primary, that is the only presently approach possible in this patient. Surveillance, how to do is the only thing. Again, repeat blind biopsy or repeat endoscopies, pyrendoscopy or PET CT, maybe the additional option to do the mainly concentrating on the pharyngeal axis. That is the main site of primary possibly because in the proximal neck. So that is mainly for the postgraduate level. At this level, if they say this much is more than sufficient, I think
Yes.
may have to
Yes, sir.
add on to about little more about the MRND and what are things to structure they will remove. The thing in the
Yes, sir.
type 1, 2, 3, what things
Ajay,
they
yes,
got.
sir.
Yeah, please.
Megha, you have said it correctly. In this case, the indication there is no indication for surgery. We go for chemo, radio. You shrink it, then reassess it, and proceed again with radio. And if possible, once it's mobile, you go for dissection. What
Yes.
are the types of neck dissections that you know theoretically?
ದುಡ್ಡು ಕೊಡೋಂಗ 6,000 ಅಂತ
So radical neck dissection, modified radical neck dissection, mainly we perform, in this case, radical neck dissection is
No,
indicated.
Megha, just tell us theoretically what are the things. You told us the classical
Huh.
radical neck dissection. You have told us modified radical neck dissection. What are the other types?
Like,
Bilateral neck dissection,
No,
omohyoid.
that is a variant of something else.
Later.
What is the other?
Okay. Before
That's
something
much
you said
later.
omohyoid, what is that?
Yeah, what do you call that subheading?
Supraomohyoid.
Supraomohyoid neck
block.
dissection.
Then selective dissection.
block.
Selective
Yeah,
dissection.
we call it selective neck dissection because again it depends on which compartments. There are 3 compartments. After that is what you said. There are some conditions of the neck secondaries where you have to do both sides.
Yes.
That is bilateral neck dissection. Since you dug your own grave, we will ask you which areas of the neck will have where you have to do bilateral.
Bilateral dissection. Other than thyroid, forget about thyroid.
Yeah, forget thyroid.
Sir, if secondaries is on the
Where
both
which
side,
primary will go ahead with the
Primary.
dissection? More like
which primary
Primary
we will go?
whether it is buccal mucosa or anywhere like that. That's what Professor Robin is asking.
Can you give us some sites where there is propensity because the reason you're doing bilateral is because it's both the place, right?
Yeah, that's what he has already given the answer. Only you have to
Yes,
tell the
sir.
word.
Tonsillar, sir.
No, tonsil is totally side. Where lymphatics are cross communicating in the oral cavity.
Sir
Normally.
has given clue. Sir has given clue easily. Beyond this, I think no more.
Buccal mucosa.
Aha. Tongue, no. Tongue.
Tongue. Yes, sir.
Lower lip. Lower lip.
Lower lip.
Tongue.
Lower lip, tongue, floor of the mouth.
Floor of-
Cross linking.
More likely they will land with the bilateral neck dissection. Okay.
Yes, sir.
We'll remove the IGV both side in such situation.
What do you do in classical radical neck dissection? What
Sir,
are the
we
things
will
you room? Huh.
Yes, sir. Sir, we will remove first to 1 to 5 lymph node. Level 1 to 5 lymph node we'll remove. We will remove sternocleidomastoid, spinal
Okay.
accessory nerve, internal
Yes.
jugular vein, submandibular
Yes.
gland, lower part of the parotid gland. Yes, all these will remove.
Yeah. So basically, fat, fascia, skin, all this portion, including the
Fat,
three
fascia,
images.
skin. Yes, sir.
Yeah,
All this will
all
remove.
that you have two glands you will remove, three structures you will remove. Absolutely right. What is the
Yes, sir.
difference between that and modified radical neck dissection?
So in modified radical neck dissection, we will preserve three structure. It is of three type: type 1, 2, and 3. One,
Yes.
we
What
will
is type
preserve
one?
the.
Wait,
So
Mega,
in type 1,
Robin,
will
Robin, just will I'll ask Ajay to answer this one.
Yes, sir.
Yes, I was wondering because Ajay was.
Sir,
Yeah.
modified radical neck dissection is of three types, sir. So in
Yes.
type 1, the spinal axillary nerve is preserved. In
So
type
nerve is
2,
preserved in one.
yes,
Okay.
one.
Type two,
Yes, sir. Type 2, the spinal axillary nerve and the sternocleidomastoid muscle is
muscle is
preserved.
it? Three.
And in type 3, along with these structures, the internal jugular vein is preserved.
So
Internal jugular.
basically, all the three are preserved in type 3. What
Yes,
is the
sir.
other name of type 3 modified radical neck dissection?
Other name,
What is that
sir,
called?
it's
If you are preserving
primes of
nerve,
it.
which is very
Primes,
important, if you are preserving
primes.
muscle and you're preserving the vein, what do you
You
call
are
it?
you are preserving the function of three structures. What it is called?
Sir
You
has given you, sir has given clue.
are preserving the function of the three structures. What it is called as? It is called as functional neck dissection.
It's called
Functional.
functional neck dissection.
functional
That's
neck.
it. Yes, that's it. So you have modified radical. That's very good. So you have then selective type where depends on the level, depending on what is involved, we will remove only that. Anterior compartment, lateral compartment, jugular-digastric omohead, everything. Very good. So if you we know all this now. Now Mega had mentioned something about bilateral neck dissection, and
Yes.
Sir asked, "What will you remove in bilateral neck dissection now?"
Sir, in
Ajay,
bilateral neck
Ajay, Ajay,
dissection,
Ajay, Ajay.
Oh, yes, sir.
In bilateral
In,
neck dissection, will we remove
yes,
all of them or will we preserve something? This is what SRB sir had asked.
Which one
What is
you
a
want?
simple answer to this?
sir,
You
we'll
want
preserve the
which
internal
one
jugular
preserve?
vein, sir. We'll preserve the internal jugular vein.
Okay, at least one side you have to
Sir,
preserve the internal jugular vein.
because it can cross, like if we remove both, it can cause intracranial tension.
Okay, so it will cause problem. Integral pressure will increase, and it will be dangerous also. One, the IJB has to be preserved. That's important.
Yes.
Okay. So there are so many things which we are not going to ask because it will be
Yes.
beyond witty level. That is,
Yes.
but basic thing, whatever we have discussed about the neck dissection, you have to know. And staging, you have to know. We are not going to discuss. You can always read about that. And
Yes.
when it is mobile only, we'll do that. When it's mobile only, we'll do the neck dissection. Otherwise,
Yes.
you won't do. That's a concept.
Yes.
And every different things already. Professor Robin has clearly highlighted: radical, modified radical, selective, and functional. Meaning MRND3 is the functional type. That's what he said very clearly, very precisely. He has mentioned that. So that much, if you know, that is sufficient. It's a very common short case kept in the exam. So 3 DDs you have to remember. Secondary is lymphoma, tuberculosis. Okay. So. Robin, briefly, this is what discussion that these discussions are sufficient for them, I think, no, but they have to read a
Yes, sir.
lot.
I think both.
But,
So both
next
of them have presented very well.
yeah,
They've
that,
answered all the questions without any stop
they have
or break. In
presented
fact,
very
they've given
well,
a reason for it also.
both of them
Thank
presented
you,
very
sir.
well. They are
Thank
different.
you, sir.
Yes.
And
Yes.
before I'll put my slides briefly, before that, Kishan, give a final comment about the presentation and Kishan.
Excellent presentation, sir. I really enjoyed both of their presentations and the way they answered.
Thank you, sir.
Initially, I thought that it's a PG presentation going on. Just now, like at the end, when you mentioned only, I came to know that these are UGs. And from the beginning, I was thinking that
This
both
is
of them are
discussion.
PGs.
You
The way
undergraduate.
they, no, sir. Initially, I thought it's a PG discussion going on, but later on,
Right.
I wanted to.
I think
Sorry,
Kishan,
yes, sir.
it's our time. It's times have changed from our time. These our undergraduates
Yes, sir.
have
Yes,
become
sir.
better, like
Nowadays, they are
postgraduates.
much more knowledgeable than us. Yes, sir.
Yeah, they are like
They have
postgraduates now.
everything in their fingertips. SRB sir has
Exactly. Yeah.
given so many books
Yeah.
that they are reading everything and they are so much more knowledgeable than us. In our time, only one or two
Absolutely.
books were there.
Yes,
Sirs.
absolutely. Oh, just
We read
yes.
only 2 books, sirs. Nowadays, it's 10 books are there. So, so all
Absolutely.
credits to
Very
SRB
good.
sir
Yes.
for making all the
Yes.
medical
Yes.
students more and more knowledgeable. His
Yes.
books are the best, so very vast,
Yes,
and
sir.
all the contents are involved in that. So
Yes.
excellent books. So I wanted one everything, most of them, whatever I wanted to ask already. Professor has covered, Robin sir. So even I learned many things from Robin sir today. Two things I wanted the one especially one thing from UGs. What do you understand by
Yes, sir.
tumor necrosis? Since sir has already brought up that, I want you to understand what is tumor necrosis. What's really happening there?
Ajay, what is the tumor necrosis?
No, not Mega, no, not to Mega, not to Robin sir. I'm asking the UGs. They should understand what do you mean by you keep on telling no tumor necrosis since your second year MBBS. You have been telling this tumor necrosis.
Ajay, can you answer the question?
There is a release of inflammatory factors like tumor necrosis.
What do you mean by no? It's simple. No. Don't get confused. What do you mean by necrosis?
So it is the
Death of the
death of the
tissue.
tissue.
Death of the tissue.
Yeah, right. It's a microscopic cell death is called necrosis. So tumor cells are dying. Why they're dying? Sir was mentioning there and all. See,
Why they are
the tumor which is the farthest from every tumor has got some blood supply. Every part of every
Yes,
organ
sir.
has got some blood supply, right?
Yes.
So when the tumor grows from that organ, the number of cells outgrows the new vascularization.
Yes.
The new capillaries, whatever is formed, the number of cells outgrows them. So tumor is growing very farther, it's
Faster.
growing very fastly, whereas neovascularization is not picking up that fast. So
Yes, sir.
the farthest, whatever which is far away from the organ, that is undergoes ischemic changes. That's why you get at the which is the most dependent area in that tumor or wherever, there you get the
Over the
necrosis.
summit. That's why over the
Skin,
summit.
okay? That's a good understanding you should have. Okay.
Yes,
Yes,
sir.
So, what do you mean by scrofula? Anyone?
Scrofula, what is the meaning? What is the other name?
It has been a long time since we heard this term, scrofula.
Don't know.
Nowadays we don't. Yeah.
Long time.
It is there in my book.
Yes,
Yeah,
it is there in
that's
Sir's book.
Image is there. Yeah. That's why. Yeah.
Scrofula is a tuberculosis. Okay.
Oh yeah.
Tuberculosis, discharging tubercular
Scrofula is a
lymphadenitis.
tuberculosis lymphadenitis. Okay.
Yes, sir.
So, Robin, I'll just go through that. Kishan, my slides, I'll
Yes,
go
sir.
through
Yes, sir.
Kishan
Yes, sir.
for
Yes.
them,
Yes.
their purpose. Both are presented well, discussed well at UG level. That is, but
Thank you, sir.
that orderly should present,
sir.
I think, Kishan. You'll agree. Professor Robin also will agree.
Yes.
I think students will get benefited. So, I'll just briefly, the history already we have detailed. What the three things we already discussed. Secondary is how it looks like. Lymphoma, India are consistent. Tuberculosis is localized. It is the cholesterol diet, there's cold diet, the stages you have to remember. 5 stages are there, that also you have to remember. Because discussion may get deviated towards the lymphoma and tuberculosis instead of that. Because examiner may discuss it is probably lymphoma, how we'll manage. We should know, have the basic idea about the HL and NHL and management also. So better to read about tuberculosis stages and its management, zigzag method, aspiration, non-dependent drainage, all those things also important. So you should remember about these three conditions: its management, approach, concept, everything. Always in clinical side or any neck swelling management or lymph node swelling. So secondary is lymphoma, tuberculosis. Secondary is lymphoma, tuberculosis. These things always you have to remember when neck swelling when you see. That's the important thing about highlight. That is a picturized view how exactly it looks like. Next slide, Shreya. So chief comes already swelling, pain, other history, orderly. First thing comes, then orderly present like that. Put the chief clamp. Next slide, Shreya. So these are the history again: swelling, pain, fever, other lump, pressure symptoms. Already they have put it in orderly fashion properly. Severity, ulcer, sinus, detailed history of each one, and oral cavity history. That's important. You already mentioned that loosening tooth, difficulty in opening the mouth. That is also very relevant because neck, oral cavity, neck. If there's a lesion in the oral cavity, neck should be examined. That lesion in the neck, oral cavity should be examined. Otherwise, examination is incomplete, the wrong actually clinically. And past history of swelling, past history of treatment, surgery, drug intake, probably patient might have taken antitumor drugs which is not incomplete treatment. It's important. Tuberculosis, spinal disease, diabetes, leprosy, malignancies, all those things should be asked for. Family history, already discussed about that. Menstrual history again in females may be relevant. Next slide. So general examination again, pulse, blood pressure, body weight is important, especially in nutrition. The loss of weight occurs in tuberculosis, even in lymphoma, even in secondary in advanced, not in early stage. So again, clubbing may be relevant to smokers. And lymphadenopathy is important when it is a lymphoma. So that's why all these things are important. Anemia, jaundice. So you have to make a point of that. Next slide. So again, I put in the chart for students for both swelling, whatever the way they have mentioned. Location is important. No, back location is important. Remember, this is sternocleidomastoid muscle, and Professor Robin already told that time exact anatomical location is very relevant when you say the neck swelling, lower part, upper part, in relation to sternocleidomastoid muscle, which triangle he has already shown actually, which triangle it is. We have to show that definition of this swelling is very important. Border, ulceration, pulsation, impulse or cuffing. Image is not very relevant because only laryngeal still will the impulse, but in the book it is mentioned. Pressure effects are important. You already mentioned wasting, also important. Temperature, size, localized temperature, swelling, surface consistency. Immediately after surface consistency should come. So orderly fashion. The order is important. Fluctuation when it is there. Transformation you have to check. Versatility, thrill, plane of the swelling. That's important. Mobility, fixity, deeper structure. Everything we have discussed. We put it in a nutshell actually. And examination proximal and distal to the swelling. And sympathetic chain again we have discussed it in detail. Horner syndrome. Why? Carotid artery pulsation, superficial temporal artery pulsation, not maxillary artery. Don't mention maxillary artery,
Yes.
mega. That is
Yes,
now
sir.
we will be in trouble. Okay.
Yes, sir.
And neurological state, spinal accessory, hypoglossal nerve, sympathetic chain. You already told vascular system. We have discussed, and laryngeal crepiters. And in upper limb examination, the lower swelling, lower part of the swelling in the posterior triangle, lower part, subclavian triangle, when there is a swelling, then you will look for the upper limb edema, pulsation, all those things. Otherwise, it may not be relevant in this case because it's the upper part. So even if it's relevant, you have to examine the upper limb also. So next slide. So other exams, cervical lymph node, oral cavity, scalp, parietal sinuses, ear, nasal cavity. Make a point always, especially when you think that clinically unknown primary. In serious, maybe there may be primary. Other than faces, he has told parapharyngeal patient, other faces, there is also important retropharyngeal patients. Posterior the tongue also you have to examine. You know how to examine from behind, a finger inside, other side. Avoid them to bite your finger.
Yes, sir.
From behind, hug the patient and feel the posterior of the tongue. Okay. Always tongue should be palpated, tongue within. That's the point again. Remember, tongue should be inside, not outside. And auscultation for bruit or the swelling, and percussion in the terminal area, and systemic examination. Other regional lymph node exams are very, very important. That's also important. So next slide. So clinical secondary is in the neck, right side level. You have to mention. I'm just putting how will manage evaluation treatment, FNAC, biopsy. Second is for lymphoma biopsy you have to do. Second is in advanced case you are allowed. PET-CT in this patient is quite relevant. CCT head, neck, chest. MRI is mainly for soft tissues, and CCT is both are complementary to each other. CCT is mainly to the lymph node status to find out. MRI mainly soft tissue involvement, especially base of the skull. When this extends to the base of the skull, MRI is more relevant. And biopsy from primary, there is blind biopsy or surveillance biopsy. You said already Professor Robin has discussed which all sites, posterior the tongue, fossa, professor lateral was pharynx, pharynx, and so on. And currently, of course, markers have come for squamous cell carcinoma also. So the markers, if you able to remember, we can read it out and keep it in mind. So these are the investigations you have to do in this patient. Okay. Then decide staging. And staging, I'm not going to discuss. Levels, I presume understood that you will be knowing level 1A, 1B,
Yes,
2,
sir.
3, 4, 5,
Yes.
like that.
Oh, fine.
And
Exactly.
N1, 2, 3 staging, so best read it out and
Yes, sir.
the meaning of extranodal extension, NE, that is relevant. Okay. So I'm not going to
Yes.
discuss that. You can always read it, but that's important. Next slide. So this is the next secondary. Next slide. This is the tuberculosis. That how it differs. This is the again lymphoma. This is the lymphoma. So this is the see that next secondary here. Thundercard muscle is involved. So look is very important. By looking at the swelling only, many times you'll be able to clean the diagnosis. It's a very clear cut picture as it is. Next slide. So this is the fungating one. See that this is again
Yes.
secondary. See that this is the platysma involved. The platysma sign it is called as. Platysma is involved here. So platysma sign. See the typical lymphoma here. See that diffuse
Yes, sir.
involvement. A typical look is this. So in bronchial cyst, sometimes it can a dark play. This one you can always check the tonsil in the dark room. Some swelling lymph cysts, bronchial cysts are the some bronchial cysts are the tonsil. Always check in the dark room. So it's a brilliantly tonsillant. Okay. Then if it is thyroid swelling, should always ask the patient, give a cup of water and ask the patient to drink. Next slide.
Sir, may I ask one small question just to make a small point?
Okay.
Sir has mentioned about transillumination test here. What are the three conditions where you have good transillumination in the body?
Okay. Okay,
In the
right.
neck, sir has said branchial cyst. What is the reason for transillumination?
What is the
Why
Cystic
problem?
it's
and consistency. It's cystic and
Cystic,
consistency.
Cystic
okay.
consistency.
You have to then what? Why it is translucent? What it means? If it is translucent, what it means? What is the content?
Liquid. The this thing
Liquid
was
fluctuation.
yes.
what is inside? That same thing is there in two other
Fluid.
conditions. One is
Fluid.
again in the
Yes, sir.
oral cavity, and one is up and one is
Hydrocele.
down.
Hydrocele.
Yeah, one is down, that is hydrocele, one is
Hydrocele, yes, sir.
inside.
Yes, sir.
Oral cavity,
Oral cavity.
frog-like.
Granula.
Ranula. Okay, ranula
Ranula.
is translucent, and hydrocele is translucent, especially in
See.
European countries. Here, many hydroceles are not translucent, but it is translucent. And cystic hygroma is translucent, and lymph
Yes, sir.
cyst maybe.
Cystic hygroma.
Bronchial cyst,
Yes, sir.
sometimes it's translucent.
One thing I want to highlight there, students, the prerequisite for doing transillumination test is what when you do not in all the cases you do transillumination. Only in what is it? Already Ajay has mentioned that word. What is the prerequisite before doing
Cystic
transillumination?
Cystic
consistency.
Yes,
consistency.
yes, very good. The consistency you check
Yes, sir.
first.
Yeah,
If,
soft
whichever has got
fluctuate.
one of my, I still remember in my time, one of my exams had failed. One of the brilliant student just for doing transillumination test in the thyroid, like firm thyroid swelling. Okay,
If it
the
is
candidate was
fluctuant
failed.
and
Okay,
soft,
so there is no,
then
because
you
that
do
shows
the
that there is a
transplantation.
knowledge is there, but there is no application of knowledge. So be careful. This fluctuation test and transillumination test holds good only for when the swelling is cystic in consistency. Is it
Cystic.
clear?
Yes,
It's not
sir.
in
Fluctuation.
all swelling.
If it is fluctuant, you will check the translation. Once you say fluctuant,
Yes,
next word
yes,
is whether it translate or not. If it is
Yes.
translation, like Professor Robin has asked, it contains clear fluid. That's important.
clear fluid.
And only
Only
Yes.
swelling, few conditions have a clear fluid. That's the point
that's
to
why I
make.
mentioned primary hydrocele. When secondary hydrocele, usually it will be chylous and all. It won't give you transillumination positive. Okay.
Then if they ask
Yes.
primary, you can mention. Okay.
Primary.
So okay. So next slide. Shreya. So again, bilateral neck swelling. See that neck lymph nodes here, bilateral. So what this is the fungating one again. Everted edge you can make out. Again, it's a lymphoma. This is again the submandibular lymph node, maybe salivary gland. So bidigital palpation is important. So submandibular salivary gland
Yes.
is bidigitally palpable.
Bidigitally palpable.
Lymph node is not bidigitally palpable. It may be primary also. So you have to like this again tuberculosis. See that how it looks. So look is very typical. You should immediately have the idea what it probably could be. Whether secondary is lymphoma, it may overlap, but many times. But usually we'll have the idea by looking at the patient. We'll be able to get the diagnosis. Next slide. Say next slide. So this is the sinus. See that tubercular sinus, impending sinus here. Cholesterol abscess, typical.
Cholesterol.
This is unlikely
Yes,
to
sir.
be having any other condition. So look is very typical. The cholesterol, you know the cholesterol abscess. Stage 5 stages are there.
Yes,
So
sir.
it's
Yes.
impending sinus formation. Okay. So next slide. So remember relation to tenocardial muscle. Remember neurovascular relation. Remember plane of the swelling. Remember mobility, fixity. Remember surface next to consistency. Remember examine one side first. When you examine the lymph node, one side first and other side, you know that. Don't examine both sides.
Yes, sir.
Don't forget oral cavity examination. Don't forget examine other lymph nodes. Detailed history is essential. Remember. And remember to examine. Already we have discussed thyroid, larynx, trachea, ear, nasal cavity, pharyngeal cavity, salivary glands. Professor Robin has specifically asked actually. Salivary glands you have to examine, and cervical spine already you have mentioned. So these points you have to remember always in any neck swelling. Understood? So this is the very relevant thing in examination of the neck lymph node neck swelling. Next slide. So that is my book, clinical book, fourth edition with video. My book manual is there. My operative surgery is there, mainly clinical book and this one. And my website, daily lectures are there. All of you go to subscribe and go through. I request all students to subscribe, go through it. Of course, live sessions, we'll plan it out regularly. So my digital lectures also there through JP Publishers. So next slide. So this is the QR code for my website. So Robin, final one word
Yes, sir.
comment how they did, and
Absolutely fantastic. I think two words.
Thank
okay,
you, sir.
they
Thank
did
you.
it, they prepared well. Hope they will continue this one
So,
again.
it's I think like what so Kishan was saying. I think our undergraduates are becoming like postgraduates. It's very difficult to gauge them. That's why I find it difficult to ask question
Yeah,
because next secondary is a PG PG topic.
Yes, sir. It's not usually for UGC lecture.
Yeah,
Can be kept test
Yeah,
short
that
case, whatever a long case, but they have
because
presented very well
They
long case.
presented,
very well, yes.
they had
They
a clear
prepared
idea.
well. They have prepared well.
They prepared well. They had a clear idea.
Yes, exactly.
Whatever this one with the small mistakes which we have highlighted. Otherwise, they
Yeah.
presented
Yes.
well. They've done well. I hope all students joined here and eventually
Will definitely get
our website
benefited by
regularly.
this
Hope
well
they
prepared
learn
presentation.
how
Yes.
exactly this one they have presented well. Hope all students have a clear understanding of about how how to examine neck lymph nodes with their proper differential diagnosis. Again, we were stressing three DDs they have to remember. Secondary is tuberculosis, lymphoma. Secondary is tuberculosis, lymphoma. You always it comes words within these three. That's the point which we want to highlight or project actually. So other things, everything we have discussed detail. They can always go through my clinical book and my website, whatever required thing. So everything is in there in detail. My book manual and this one. So I thank Professor Robin always joining with me with this knowledge, of course, expressed to everybody with a very clinical theme and thinking. His analysis is very good. Kishan, thank you very much for joining. He said he'll join through YouTube message. I said don't join. You come through the Google link with us because as a faculty rather than through YouTube. Thank you, Kishan, accepting and joining me to
It's a
this.
great honor being with
Uh,
SRB all the time.
I appreciate
Yes.
and hope students who have joined and understood if
Yes,
we
sir.
learn something, I'll be
Yes,
very
sir.
happy.
Thank you so much, sir,
Thank you,
for
sir.
giving
Thank
this
Rekha and
opportunity, sir.
Jay. They presented well and prepared
Yes.
well and with this live session. And thank you one and all. Robin, I'll be in touch with you, Kishan.
Thank you,
Again,
sir.
thank
Yes.
you,
Thank
Kishan,
you.
for
Thank you, sir.
Anytime, sir. Anytime.
thank you everybody and thank you all students. Hope you enjoy session. Hope they have learned this examination neck properly. So with this we'll wind up. I thank Shreya, then Shubhank and Aditya, who are the backbone of my all these arrangements and things. Because I just come here, everything they organize, link everything. They're absolutely perfect. I think Robin, you know them well. So all the people they are doing very good job. So I don't have any hurdle about those things to work on that. I think
Kishan, it is nice meeting you for the
Same
first
here, sir.
time.
Same
Kishan,
here.
I
Yeah.
think you have met Robin, sir. I don't know, Professor Robin.
No, sir.
I'm
I just
I don't
meet
know
him.
where I think maybe in the PG clinic session, sir,
Kishan,
because I have seen his
Kishan will
I
be
have
meeting
yeah.
everyone. He has got a vast knowledge
Yes.
of everybody, all
We attend because
everywhere.
we all attend the
He'll
same
be in
session,
touch
PG
about
clinics.
everybody.
Everyone from Kerala and everybody is there. Yes.
So with this,
Megha and Ajay, very good.
Yes, sir.
We wish you the best for your
thank you very
university
much.
exam. I hope
Thank
Thank
you,
I
you
will
sir.
not
so
become
much,
your
sir.
examiner.
Again, I appreciate everybody. Hope students will learn. With this, we'll wind up and take care.
Yes.
Good night. Thank you, Robin.
Thank you,
Thank you very
everyone.
Thank you
much,
so
Thank
much,
you,
Thank you,
sir.
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 Thank you so much.
Thank you, Kishan.
Thank
Thank
you.
you.
Yes, sir.
Thank you,
Thank
sir.
Good night. Good night.
Thank
Bye,
you.
Kishan. Bye.
Thank
Thank you,
Good
you.
sir.
night.
Bye, sir.
Thank you. Good night. Bye, guys.